Hello and welcome to the Clinical Care Options Infectious Disease podcast. I'm your host, Zachary Schwartz. In today's episode, we cover the latest COVID-19 data presented at IDWeek. I'm joined by our expert faculty, Dr. Arthur Kim from Harvard Medical School and Dr. Renslow Sherer from University of Chicago. If you'd like to see the data on the studies they'll discuss, you can follow along with the slides. Just go to the link in the show notes. But let's get started and turn things over to Dr. Sherer.
Well, thanks so much, Zachary. And we thought we should start just by trying to give a snapshot of where are we with COVID-19, with some estimated 103 million confirmed cases in the United States. And if you break that down to hospital admissions and deaths, you can see the cumulative totals of 6.4 million admissions, 1.1 million deaths. And looking at it in a weekly way, which the figure tells you a little bit better, 16,000 hospital admissions in the week of October 1st to 7th and 549 deaths. And you can see that since August, we've had an increase overall in hospitalizations. And I think it's a very challenging time for clinicians and for our patients who listen to us with all of the moving parts in COVID, with the new bivalent vaccine and the fact that some of our at-risk individuals have had boosters, some have not. We still have a need for recommending isolation and symptom management, very importantly for people still to ascertain testing to decide whether or not they're infected, in part to take advantage of the availability of antiviral therapies that can reduce the risk of hospitalization and death. And of course, we have the continuing variations in the Omicron strains, BA1, BA5, and now the more recent EG5 and others. And so I think it's really a difficult time for understanding what's happening out in the world and what are the impacts of some of the interventions that we've already taken in process. So I'd like to start by thinking about some real-world outcomes from the large United Kingdom database for immune-compromised individuals, including those with end-stage renal disease, and then explore a little bit what we know about the new bivalent vaccine and its efficacy in comparison to the old vaccine, its real-world efficacy in elderly folks and immune-compromised, and then also look back at some of the impact of boosting. So let me start with the lovely INFORM study from the United Kingdom that has just used all individuals as part of their database. So this is 11.9 million individuals who are over age 12. And we're going to look at two different populations. First, focus on end-stage renal disease as a risk, which we know is an increased risk, but this is to try to quantify the degree of risk. And then another population of those who are immune-compromised, some 470,000 in that grouping. And you see the listing of the definition of immune-compromised, which is quite comparable to the CDC's listing in the United States. So it's very important to understand that among those with end-stage renal disease, there's overlap. They're more likely to be over age 65, to have multiple comorbidities. And most of the folks that we're going to talk about have had 3 or more vaccine doses. So this will be a fully vaccinated population. And you can just understand the degree of risk. While it's only 0.2% of the study population, it's a 10-fold increase of risk of hospitalization. So 2.8% of hospitalizations are in folks with end-stage renal disease. And again, more than 2/3 of those with greater than 3 vaccine doses. And similarly, 3% of COVID deaths also in vaccinated individuals. And if you look at the crude hospitalization numbers, they're in the range of 25 and 24 if you exclude those who've had kidney transplants. And then if you look just at those who are vaccinated, there's an impact reducing to 23 and 21, but the overall adjusted rate compared to normal hosts is still in the range of 3.8 for all patients, 2.8 if you exclude kidney transplants among those who are vaccinated. So still a 2 to 3-fold increased risk compared to the general population. And that translates similarly for the risk of death in the population with end-stage renal disease. If we turn then also to look at immune-compromised individuals, they are also, as a population, more likely to be over age 65, to have a greater number of non-immune-related comorbidities, and also to be fully vaccinated. And here again, while that's only 3.9% of the total study population, this population accounted for 21% of hospitalizations and 23% of deaths. And if you look at the crude hospitalization rates, they're 9 per 1,000 adjusted in comparison to normal hosts. That's a 2.1, 2.17 greater risk, even among those who are fully vaccinated. And similarly, about a twofold increase risk of death as compared to the general population, even among those who are fully vaccinated. So that clearly defines, I think, some of the problems that we're seeing. And I thought it was important also to further characterize those immune-compromised individuals because there's clearly degrees of risk within that category. And the highest rates for risk of hospitalization and death, as you see here, are for recent transplants recipients led by stem cell transplant and organ transplant recipients within 5 years. Those with primary immunodeficiency, where the rates are 5-fold higher, and end-stage renal disease and hematologic malignancies, where the overall IRR is in the range of 3.6 to 3.8. Secondary immunodeficiencies, which would include folks with untreated or uncontrolled HIV disease, advanced HIV disease, are in the range of 2.9 increased risk for hospitalization and a 3-fold increased risk of death. And at the bottom of the list is solid tumors. So I think this helps us to understand the variations in the degree of risk in the patient population who are most at risk. So the key points from this section in the outcomes is just, first of all, that there's a continuing hospitalization and death rate with over 500 deaths per week in the United States. That will translate to 25,000 or more deaths in a year's time. We've seen that end-stage renal disease in the UK series was associated with a 3-fold increase in the risk of hospitalization and death compared to non-compromised hosts. And while immune-compromised persons are only 3.9% of the general population, they occupy a fifth to a quarter of all hospitalizations and deaths in that same series. And most of those individuals, more than 3/4, were fully immunized. So that's a population where we still need to do symptom management, treatment with ambulatory therapy, and to forewarn them about needs for potentially for hospitalization and emergency room visits. And among those folks with ICH, hospitalization and death was highest among transplant recipients, recent transplant, and those with primary immunodeficiency, end-stage renal disease, and hematologic malignancies. So I want to spend the second half of my time just looking at some of the newer information about the updated vaccines, in particular, those that are active, the 2019-311 against the Omicron subvariants BA.1 and BA.5 that are dominant. And so this was, I think, a really useful phase 3 analysis looking at the recombinant SARS-CoV-2 spike protein vaccines versus, first of all, part 1, the BA.1 monovalent variant vaccine, NVX-CoV2515, or both, the previous vaccine. And in the second part, also 1:1:1 to either receive the prototype ancestral vaccine, the 2373, the BA.5 specific monovalent variant vaccine, or to get both. And this was a study looking at immunogenicity and safety. And the outcomes were that the monovalent BA.1 vaccine induced superior neutralizing immune response against the matched Omicron BA.1 virus compared with the older prototype vaccine. Similarly, the bivalent BA.5 variant-specific vaccine demonstrated superior neutralizing antibody when compared with the prototype vaccine against the BA.5. Neutralizing immune responses were about at the level that we've seen with previous vaccines, around associated with 82% vaccine efficacy, so indicating very good short-term COVID-19 protection, and then really excellent safety that was comparable with the known safety profile for the prototype vaccine. So very reassuring that these targets, looking at the new spikes in the Omicron B.1.5 and BA.1 and BA.5 subvariants, are effective. So the next question is, what do we know then in more recent data about the efficacy of the bivalent COVID-19 vaccine against hospitalization? So this is looking at a group in the IV cohort from September to May of 2023, where cases were defined as those individuals known to have a positive test within 10 days of symptom onset, as compared to controls people who have a flu-like illness and a NAT or antigen test negative within 10 days. And you can see that they were stratified by 6,000 immunocompetent individuals and 2,000 immunocompromised individuals. So the vaccination status that I'm going to show you is unvaccinated individuals compared to the monovalent vaccine, the bivalent vaccine in the short term within 7 to 89 days of vaccination, and then a bit of longer term follow-up from 90 to 179 days. And remember here, the outcome of clinical interest is COVID-19 associated hospitalization. So there's a lot of information on this slide, but you can see that in comparison to monovalent only, the bivalent short term for immunocompetent adults overall was 51% vaccine efficacy, really excellent efficacy. But looking at that over a prolonged period of time, after 90 to 189 days, there was a substantial waning of that effect, so that vaccine efficacy fell to 12%. If we go then further and break that down, first of all, by age groups, you can see very similar results for both the 18 to 64 years of age and the greater than 65, though there was a somewhat higher response rate, so vaccine efficacy in those who were over greater than 65 years was 53%. In those who were 18 to 64, it was 43%. But in both cases, there was substantial waning after 90 to 189 days of that effect. So strong initial effect, but durability was a challenge. And if we look at that then by comparing immunocompetent members of this cohort to those who were immune compromised, you can see again excellent efficacy in the short term, 7 to 89 days, of 51% for immune competent, 55% for immune compromised. But you notice that among those who are immune compromised, there's a more durable effect, so that in the second period, 90 to 189 days, still vaccine efficacy up to 43%. And then the last study that I want to share with you is the COVE study that basically looked at boosting with the previous vaccine products during, first of all, comparing the different waves, Delta and Omicron, and also looking at a different dosing interval. So the way this study was structured, you either received 2 doses of the mRNA 1273 or placebo, and you were in the early vaccinated group from July to December 2020, or you got the vaccine late from December 2020 to April 2021 and the placebo. So there's 2 groups of 8,000 individuals each in this group. And then we're going to look at outcomes by, first of all, by the strain of virus at the time. And you see an excellent response rate of protection from the Delta during the Delta era of 83%. And that was sustained over the 60 days following the booster. Whereas with Omicron, because Omicron has greater infectivity and more action at the spike proteins, the initial vaccine efficacy is only 56% and down to 4% over 120 days. Also, interestingly, there was a much more pronounced effect for those who were over age 65 of 86% protection. That also waned down to 28%, but was substantially greater than for the under age 65, where the initial response was 15%, and that waned to 6%. And very interestingly, there was a difference also seen in the dosing interval of the boosting dose. The early vaccine group had 12 months between the second dose and their boost. The later vaccine group had an 8-month. And you can see that overall with Omicron, with the post-boost, there was an advantage to having a longer period, a 12-month period between boosts. So the longer boosting interval of 12.9 months actually reduced the risk of Omicron to a greater degree than the shorter boosting interval of 9 months. So let me summarize the second section, and then I'm going to turn this over to Arthur, and we're going to talk a little bit about updates in treatment. So we saw that the monovalent vaccine against BA1 and BA5 induced superior neutralizing immune responses against the matched Omicron BA1 and BA5 compared to the prototype vaccine, with 82% vaccine efficacy and known safety. In adults who are over age 50 years, COVID bivalent mRNA vaccine reduced hospitalization by 58% after 2 to 3 months, but the effect waned to 19% after 4 to 6 months. And the vaccine efficacy was more durable in the immune-compromised hosts in that series, which waned, but only to 43% after 4 to 6 months. And then very interestingly, the boosting with the mRNA 1273 gave additional COVID protection during both Delta and Omicron. It was more pronounced in the Delta wave than with Omicron, and it reduced the risk of Omicron, but waned over time after around 4 months. The effect overall of boosting was greater with those who are over age 65, reinforcing how important that has been in that age category. And interestingly, there was a longer interval was associated with better protection from Omicron infection. So let me stop there, and we'll have questions either now or also at the end. So Arthur, I'll turn it over to you.
Great. Wonderful presentation, Dr. Sherer. I guess we will save some of the questions for the end so we can get through the presentation. But while we're have some of this fresh in our minds, I thought I'd ask a couple of them. In the later study, one of the listeners asked, why was the bivalent vaccine more effective in immune-compromised compared to in normal hosts? I think that's kind of a philosophical question, but the data may or may not show us. But you can think of a couple of potential explanations. What do you think?
Yeah, I mean, I think you might answer that with that there's more distance to go for those who are immune compromised. They need all the support we can get. In fact, we've seen evidence that there's additive benefit to more prompt and timely boosting in that population, a greater additional benefit to the use of antiviral therapies also in that population. So I think in general, the reason that it's more effective in that group is they need more support. Now, whether or not as a gross number, that means that it's overall more effective in preventing vaccination or preventing infection than in non-compromised hosts is a different matter. And that's a different comparison. Arthur, you may also have an answer to that question.
Yeah, no, I would agree with that answer. It seems like the immune compromised are sort of where we feel like we get a lot more bang for the buck for our boosters. And I think that seems evident by the hospitalization data you presented in terms of who kind of slips through and makes it into the hospital due to COVID. And we know that their immune responses, depending on the degree of immunosuppression, can be quite variable. So that seems to be a target group. So this will get at some of the other more broader questions that were asked by the audience, which we'll return to at the end regarding vaccines. And so I'll spend the next segment and transition to therapeutics. And what we'll discuss are a bit of clinical trial data and some real-world data relevant, hopefully, to your practice. And I have Boston behind me in my background. And for those of you who made it to IDWeek, I hope you had a wonderful time and enjoyed our city. And we couldn't go through all the different abstracts related to COVID-19. And so if your favorite abstract did not make it to our presentation, my apologies. And so clearly the data just presented indicate the need to think about therapeutics, that there are still hospitalizations and a need to mitigate COVID-19's burden on our healthcare system, as well as consideration of other post-COVID complications, such as conditions that arise, long COVID symptoms, et cetera. So the first study that I would like to highlight is an insight into the EPIC-SR trial. The EPIC-SR trial has been presented at the FDA meeting. There's some information at clinicaltrials.gov, but many of us are anxiously awaiting kind of seeing the primary results. So this poster was able to give us a little bit more insight. And what they did was a combined presentation about outcomes from both the EPIC-HR trial and the EPIC-SR. So HR stands for high risk, and that was the trial that resulted in a rather large reduction in hospitalization and death in those who are unvaccinated and also had risk factors, and led to the authorization of nirmatrelvir ritonavir. The standard risk trial enrolled patients who are unvaccinated with zero risk factors. So you can imagine the younger individual without health problems, but who happened to be unvaccinated at the time of enrollment, or those who were fully vaccinated at that time, and enrolled them to placebo versus study drug for 5 days. And so the integrated analysis will look at efficacy and safety and will provide us a little bit of insight into that EPIC-SR trial, which we've been waiting for more details. So when one looks at the pooled data in the first column and comparing nirmatrelvir and placebo, what you're looking for is the total number of hospitalizations in the numerator, and the denominator, the number of participants. And so this 83% overall reduction, when one looks at the EPIC-HR trial and the SR vaccinated high-risk patients. So they've taken out the unvaccinated low-risk patients. And you can see really that the majority of events are driven by the EPIC-HR trial. So that's where really one gets the most bang for the buck for those who did not have prior immunity. They did look at, from the EPIC-HR trial, and these data have been looked at before, but for those who happen to be SARS-CoV-2 seropositive, so they had evidence of prior infection, and so you're looking at a reinfection in patients who had prior immunity. And there also, you can see the event rates are low. They are numerically lower in the nirmatrelvir-ritonavir arm compared to placebo. And then the rate in the SR vaccinated high-risk patients. And so this demonstrates how the event rates really changed due to pre-existing immunity, whether by vaccine or by seropositivity. And in this case, that the difference does not reach statistical significance. And so this then combines it and shows you the difference. And then they had additional analyses showing that this treatment benefit still went in the positive direction, regardless of whether patients had longer durations of symptom onset, duration since symptom onset, age, sex, BMI, underlying conditions. So there's signals, although not, I would say, definitive, that this medication can improve outcomes in persons who are lower risk, although I would say clearly the number needed to treat based on these numbers would be much higher. The study then decides to show us what types of other medical visits can occur. And if you were in the placebo arm, even in the EPIC-SR, that there was a numerically larger number of people seeking medical care. And this is outside of the hospitalization, which was the main endpoints of the trial. And you can see other health utilization statistics here. And they also presented viral load data. The treatment emergent adverse events that were seen, they are, again, lower in those who are received study medication. And this is often driven just by having lower rates of hospitalization. And remember, this is the combined trial. They're not separating things out. So most of those events are likely in the higher risk, the EPIC-HR trial. But nonetheless, you can see that the rate of discontinuation due to adverse events remains low. And there were no deaths in persons who received nirmatrelvir-ritonavir. Now, the famous taste in the mouth, dysgeusia, that we all counsel about, I'm sure many of you, was present at a much higher rate, as you see here. Then another question that comes up in addition to the question of whether antiviral treatment helps persons with pre-existing immunity, the other question that often comes up is, if I take this medication, doc, will I have a lower risk of long COVID? And there are a variety of ways to define long COVID, or there's symptomatic long COVID and the fatigue and brain fog that we see not only with COVID, but with other infections. And then there's also a way to define things by what we call post-COVID conditions, or things that arise after COVID that could possibly be attributable. And the way that we look at this is by comparing matched cohorts of persons who did contract COVID, and then following those who had been treated with nirmatrelvir-ritonavir, and then a matched cohort of those who were not treated. And so there's one published study that I looked at closely, a VA cohort study that suggests a lower rate of post-COVID conditions, but that's a VA study. And so there's a question of whether this applies more generally outside of that population. So the generalizability, in other words, of that study. And so these CDC investigators were looking more deeply into the Health Verity data set, and they included adolescents and adults, so across the age spectrum, 12 or older, excluding pregnancy, renal and liver disease, and persons who would not receive this medication due to drug-drug interactions. And so in a sort of 2-to-1 matching fashion, they then looked at the incidence of either one or greater than two post-COVID conditions. recorded 60 days or more after the index date. And so moving forward into the results, there were baseline differences even after this matching, in indicating that those who are treated were more likely to have no healthcare encounters than the previous year. They were slightly more likely to be vaccinated against COVID-19, and they were less likely to have documented prior COVID-19 infection. So in other words, the second time around. Nonetheless, because of the size of this database, they were then able to analyze by age group. And what you're seeing here is that in the youngest age group, the adolescents, that actually nirmatrelvir ritonavir was not associated with a reduction of post-COVID conditions. And in fact, there was a slightly higher, significantly increased risk of certain conditions, not a very large increase in risk. And so what this either suggests is that this medication does not reduce such underlying conditions, or that the practitioners were applying these medications to persons who are more at risk for development of these types of medications. So there's a few explanations that can emerge from observational data. And then also there was not a particularly seen effect in persons aged 18 to 49. And so it really varied across the board. So you can see these numbers are close to 1.00 in terms of the relative risk. But it was really in the older age group, the age over 50, that there's a stronger signal that there was a reduced rate of post-COVID conditions. And so you could interpret, again, from observational data, not a randomized controlled trial, that treatment could reduce some of these conditions. You'll have to take into account that there were differences in the baseline characteristics. So I wouldn't say this study is definitive in saying this, but we can continue to say remains an open question, but a rationale that antiviral treatment may assist in reducing downstream complications of COVID-19. There were at least 3 abstracts that I saw that also looked at observational data and tried to compare nirmatrelvir ritonavir treatment to molnupiravir treatment, which, if you recall, was looked at in the MOVE-OUT trial and reduced hospitalization and or death by about 30%, which was less effective than the nirmatrelvir ritonavir EPIC-HR trial. So each of these moved into clinical practice. And so the patients who are receiving molnupiravir tend to be persons with contraindications to nirmatrelvir ritonavir. But if you look at outpatient treatment in the VA system, which is a wonderful database that allows finding of cohorts that can be followed, and they, in this case, basically throughout 2022, they were able to follow patients after receipt of these treatments for hospitalization. And what you're really seeing is that the number of events, either hospitalization or death within 30 days, it was pretty close to equal. And this was true of the other 2 abstracts I saw. And so what does this mean? Again, it's not a head-to-head comparison. It could be consistent with just sort of each of these having lower event rates in the modern era, or event rates that are similar. And you just can't tell because there's not a placebo arm, a matched cohort to see whether the antiviral treatments are preventing hospitalization or death. So, I wanted to present sort of some balanced data regarding observational cohorts, and also display how we see signals that we're trying to interpret in context. And we really wish we had randomized controlled trials to address several of these questions. But we're also interested in whether therapies continue to be effective against novel variants. I mean, keeping up with novel variants is a subliterature of COVID-19 that is extraordinarily evolving. And so just as the virus does to sort of escape our immune systems. And so remdesivir and another medication, obeldesivir, which I'll describe in a moment, retain activity against the novel subvariants that were tested. And so the NSP12 protein of the virus is the RNA-dependent RNA polymerase. And so these investigators who are based at the company looked at the prevalence of mutations in recent variants, as well as the antiviral activity. Now, what is obeldesivir? This is an oral prodrug of a polymerase inhibitor, and it's currently in phase 3 trials for treatment in high-risk patients in outpatient setting. And so these are the kind of trials we're really looking forward to understand whether antiviral treatment is efficacious in the current setting. And so looking in a cell culture type system, a replicon type system, they're able to look at the efficacy. And so what there is, I mean, there were some known substitutions in NSP12, and the earlier Omicron variants displayed some variation already. So that they didn't find really novel ones in the polymerase. These are highlighting some of the more frequent ones, depending on the strain, whether it's BQ1, the XBB 1.5, which became dominant recently and now has subvariants that are important, and then a variety of other less frequent substitutions. The bottom line is that the EC50s, the inhibitory concentrations, the fold change from wild type, do not change that much. And so there's not, basically these medications retain activity. And so while there are other reports of emerging resistance while on therapy, particularly in immunocompromised individuals, so far they don't seem to be circulating much. And when circulating, they don't seem to be affecting at least the polymerase-based treatments, which is good news. And in terms of data on remdesivir, which is really our longest used antiviral since the days of Act 1 in hospitalized patients, and then moving to outpatients in the Pine Tree trial. And so there's a third trial called the Red Pine, which may not have reached your attention yet, but this looked at hospitalized patients with advanced kidney disease. You may remember that the previous label basically had caution regarding such patients with low GFR. And when you look across these three studies, they can then isolate out the hepatic adverse events. And so, diving into this just a little bit, the Act 1 trial, these are hospitalized patients very early in the pandemic, as you may recall. And these were very sick patients and often enrolled patients who are already on their way or are in ICUs. Nonetheless, and that's why there are much higher rates of ALT abnormalities, AST increases. Ultimately, you can kind of see hints that some of these signals are actually numerically lower in the remdesivir arm, and that may be consistent with some of the efficacy we saw in that trial overall in terms of the Act 1 trial. The Pine Tree trial has much lower rates. These are patients who are outpatients. And so even when you measure ALT afterwards, you just don't see too many events at all. The Red Pine trial is a hospitalized trial enrolling later. And so we've definitely improved our care of these patients. You do see some events occurring, but ultimately, the bottom line is that when one combines this and looks at the grade 3 increases, they're just overall, there's no real signal of hepatic injury. And while slightly higher in the Red Pine trial, these kind of data are likely what helps support a change to the label if you missed it in late August, that remdesivir is safe to give according to the label at all stages of liver disease, including decompensated liver disease. And so if you missed that update in late August, I think that this abstract is one of the ones that helps support that. And so the novel COVID agents in development, in terms of antivirals, we couldn't present all of these in the interest of time. We want to get to the Q&A, but I did want to highlight a few of the abstracts as they display where drug development is at. So we've already talked a little bit about obeldesivir, which is this polymerase inhibitor, and kind of like remdesivir has a low potential for drug-drug interactions, as shown in one poster. And so we're looking forward to the oral version of polymerase inhibitors that are effective. There were some abstracts on ensitrelvir, which is a novel protease inhibitor. It's actually already approved in Japan, where some trials have shown that treatment initiated within the first 3 days has shortened time to resolution of symptoms. And so these are being looked at in larger phase 3 trials. And so there will still be drug interactions with this medication, but in the absence of ritonavir, the pharmacologic booster that we all had to either learn for the first time or relearn as HIV specialists, it's missing ritonavir. So the degree of drug-drug interactions is expected to be less. I think another approach would be to find agents that target novel areas of the virus. And so in particular, we all recall the spike protein, the receptor binding domain, how it changed from strain to strain, and we progressively lost our monoclonal antibody arsenal that targeted the RBD. And so here we're looking at two compounds, just highlighting that they target the S2 subunit, which is far more conserved within the virus. And so one was a peptide. And this is looking at some preclinical models, including some murine models, and then an antibody that could actually synergize with ones that target the RBD and can neutralize both pre-Omicron and Omicron variants, including some of the later ones. And then we all recall tixagevimab, selgavimab. I haven't pronounced that in a while. The long-acting monoclonal that we gave to immunocompromised patients to help prevent COVID-19. And so at this meeting, I want to highlight a couple of more candidates for that long-acting monoclonal antibody. You'll notice one of them, the first one, is they're examining it as a single IV push. I think that's important, as you know, in the previous days of monoclonals, we'd have to monitor patients quite a while, and so it would be great to see the ability to administer these agents. And then a novel one that continues to neutralize the variants in a hamster model, including the recent BA 2.86. And so there is going to be continued drug development that match our clinical needs of fewer drug-drug interactions or novel targets in case the virus mutates further. So key points on the nirmatrelvir ritonavir question, it's definitely has been used, and there's sort of different approaches that we've seen. Really, the data from the EPIC-HR trial support efficacy of this medication, that it does do something to reduce the virus. And if you think about doing it early enough, that seems to be the approach to prevent downstream complications. However, the EPIC-SR trial, in all honesty, was a negative trial. And so while we can try to look at it and subdivide it and support possible efficacy in certain subgroups, we still need the primary data to sort through to really understand whether this works in vaccinated high-risk individuals or, I guess, unvaccinated lower-risk individuals. So the observational data studies, I think I talked about one that suggests that for older adults that it reduces post-COVID conditions. There are caveats to all observational data, and so we just need to continue to explore them in context. And that's what we're going to have for the time being in terms of data to counsel our patients as to, doc, whether this medication you're offering may reduce long COVID. But we do continue to see some supportive observational data. So I guess just briefly, what is my approach? I guess in this era, I would focus antiviral treatment to the highest risk patients, by age, really being a major driver. If you're older, in a nursing home and frail, or if you have immunocompromised, these are patients that I take care of regularly who end up in the hospital. And then as Dr. Sherer presented, the recency of vaccination may also be a factor in terms of applying whether a patient has enough protection to kind of tough it out or to apply antiviral therapy. So we do have information that some of the medications we're using retain activity against the recent novel variants, which is fortunate. The hepatic safety data from the trials looks promising. And so a reminder of the change in the label that we can expand remdesivir to not only end-stage renal disease patients, which was an earlier adjustment, but to advanced liver disease. And then additional agents are in development for the COVID-19 prevention and treatment. So thanks to this audience for listening. And I think it's time to turn to the Q&A, which is always the fun part of these. So,
well, Arthur, I have one question for you that maybe is the most commonly asked question from both patients and clinicians. Can you provide an update on COVID-19 rebound with nirmatrelvir ritonavir therapy? How often does it happen? Why does it happen? What's the clinical course? What should we do about it? So maybe we could start there.
Yeah. So firstly, as medical professionals and researchers may tend to do, we've started to perhaps overcomplicate some of this discussion. But when you look at the FDA reports, the frequency of virologic rebound and some with symptoms, some without symptoms in the trials seem to be fairly low. And so going back to the FDA presentation regarding the approval of nirmatrelvir ritonavir, but when you go into clinical practice, you realize that patients are checking themselves way more regularly than they did in the trials. So the trials just checked every few days. And so when you look for virus, guess what? You'll find more virus. And so the rebound rates in clinical practice have been much higher. Now, the updates seem to be that we still don't know the important question of whether, like, if you treat like the minute you get diagnosed with COVID versus waiting a couple of days, whether that would affect the rates of rebound. We do know that, depending on how you define it, that these are kind of around 10%, and that there's differences between the overlap of virologic rebound. There's some people who have asymptomatic virologic rebound. They're testing positive and they feel fine. And there are people who have symptoms and don't seem to have evidence of virologic failure, these lingering symptoms. So there are some nice reports, some of which are in press that I've been following. And so I'll look forward to their arrival in the published literature. And, so far we've not seen clear-cut evidence that there's a lack of like a T cell response to help control things, that there's a lack of serologic response that lets the virus out. And it seems to also happen when they follow individuals who did not get antiviral treatment at a pretty decent rate. And so is this just a characteristic of the virus? And then the last update is whether or not longer treatment can help prevent these rebounds. And I think that's an important question that we hope to answer. There is a EPIC immunocompromised trial that will examine differing courses for immunocompromised patients. I think it's 5, 10, and 15 days. And I think we might see signals of how to, look at the rate of rebound and persistent virus, since those individuals are the most likely to experience such symptoms. So that's a long-winded answer. Again, the experts tend to overcomplicate things. We know it's there. We counsel about it. We think there can be infections when they rebound on transmissions, although not always. So still in that fuzzy gray zone, I'd say overall.
Well, several people have asked just about thinking about the timing of the bivalent vaccine. And I'll read one of them because I think it says a couple of things. It says, what should be the main reason to recommend vaccination against Omicron? According to the data, Omicron is still mainly an infection of the upper respiratory tract. So thank you. And others asking what's the optimal timing. And I'll start, and Arthur, ask if you would like to comment as well. I thought that the ongoing hospitalization and mortality data alone are compelling enough for us to be very careful in recommending the new booster against the Omicron subvariants, because it's still a dreadful infection and there's still those who are susceptible to hospitalization and to death. And while I would prioritize anyone over age 65, my peers, and those who are immune compromised on that list that we discussed, I'm very generous in my interpretation of that. So I would actually start at age 50, not age 65 in the United States, because the vulnerability is substantial for anybody with one or two comorbidities over age 50, like hypertension, obesity, diabetes, etc. I am inclusive rather than thinking of limiting it to certain people. And those are the current CDC recommendations. And I think a little more difficult to answer concretely that all the recommendations say now is a good time if there's been a passage of time since the last booster. This is a different vaccine, so it's reasonable to frame it that way. This isn't a booster of the previous series. This is a new vaccine. And so the new guidelines recommend for all ages that it be received. And then there's comments on timing 8 weeks or more following a recent COVID infection or after the last boost, as an example. But I think the scientific question of what's the optimal timing and what's our best public health strategy to go forward is something there's a lot of discussion about. I don't think we have a final answer. Will it be annual vaccination? The arguments in favor of that have much to do with just the logistic difficulty of doing it more than with that regularity, and the difficulty of keeping people's attention and having them accept the need. And we do an annual influenza vaccine, so there's a certain logic to once per year updating with a new vaccine. So that's a long-winded answer. There is no simple short answer to that very important question. Arthur, how would you answer it?
Well, guess what? I'm scheduled for my XBB booster within the next hour. So I've had previous bivalent boosting over a year ago, and I've had COVID-19. in the interim, along with my primary series and third dose. So this will be my fifth dose. I'm in my 50s. And why am I getting the vaccine? So we'll just present it that way. Well, I don't have many comorbidities. I could use a little bit of BMI reduction, but I have the wastewater in our area was rising, but I have a couple of upcoming events. I may want to attend a concert in a couple of weeks, and also I'm going to be visited by my brother who does have some underlying conditions, and so because of that, I've decided to time my boost now. Otherwise, I could have waited until Thanksgiving holidays, perhaps, to boost. And so I think about it as this multifaceted equation of who you are, sort of what's coming up, and how far you are from the last exposure, and which for me is like closer to 10, 11 months. So I'm feeling like I could use a little boost. And while there are, some safety concerns, some were raised in the chat. And yes, if you look in very large databases, the vaccine does have some statistically larger signals. There's a mention about clots, particularly with the J&J vaccine. But even with the mRNA vaccines, there's a recent VA study with a very, very small risk that's higher. But when you look at the studies that look after COVID, there's a pretty high rate of VTE, of venous thromboembolism, high rates of onset of diabetes. These are things that as someone who could use a little BMI reduction wants to avoid. So I think these are the questions that remain before us. And again, discussions can take that equation of your own personal risk, upcoming events, the people that are around you, and kind of just make those decisions.
Yeah. I'm in the same boat. So I am also scheduled, my wife and I, this week. And I've recommended for all of our family members. But in each case, there's some differences. We do in our larger family pod have 2 unvaccinated individuals who are seniors. And that certainly complicates our thinking about interacting with those individuals. In that study that you mentioned with follow-up of nirmatrelvir and post conditions, some of them, like an acute myocardial infarction, was a 30% reduction associated with the use of treatment. With clots and pulmonary emboli, it was a 40%. So it was even higher than the general number. I think there's several other studies that are only observational studies that have sort of pointed the signal in that direction, that treatment and vaccination are associated with lower risk. To me, that's an additionally compelling reason to think about accepting vaccines, certainly how I talk about them. So both the acute illness and the reduction of post-COVID conditions. I think we're out of all the time we have. There were terrific comments and questions in the chat. And I just want to say, pleasure to work with you again, Arthur, and thanks to CCO for the opportunity.
Thank you, Dr. Kim and Dr. Sherer, and thank you all for listening. To see more from this program, such as slides and opinion pieces, click on the link in the show notes, and stay tuned for more podcasts. Thanks for listening.